Recording has started. Brilliant. So, ladies and gentlemen, thank you all for joining. Thank you all for attending. As I said, 6 to either 7:20 or even half 7. Well, hopefully we'll have some time for some questions and answers, some Q&A. But thank you everyone for joining in, and I hope we'll all benefit from this. So, I'll introduce myself. My name is Hashil. I'm a qualified PWP, currently working. I recently joined a new service. So I'm currently in London. I trained in London. I was at UCL. I was in one of the SLAM services. And yeah, so I was in one of the SLAM services. SLAM stands for South London and Moseley Hospital, for those of you who are not in London, or Moseley NHS. So that's SLAM. I was in one of their talking therapies. And now I've moved to Oxley's, so which is a neighboring sort of borough and a neighboring NHS trust, and I'm working for a new service. Really excited because I'm moving. I've just moved to a new role, which was I trained at my previous service. I trained there for a year with you at UCL. That's why I did my training at, and then I qualified, transitioned to the qualified role, and then after that, which is in the last sort of couple of weeks, transitioned to a new role, which is known as the LTC PWP, which is the long-term conditions PWP. So my role will be I will be doing core PWP work along with working with the integrated service, which is the the LTC team, the long-term conditions team. So I'll be doing a bit of both. But I will be taking a lot of cases that are LTC, and it's a big interest of mine. And I'm fortunate that I managed to get the position and I secured it. Um, so you've probably read, I think most of you probably had a view of my profile. So in short, yes, I've worked abroad. I'm originally from Oman. I've worked abroad. I did my undergrad here 10 years ago. I went back, managed to get a position there. So I worked in Oman for about 6 years, worked in Qatar for about a year, worked both in clinical and educational settings, and I've done a bit of youth development work and all the other stuff. I've applied for this I applied to this program 11 times. I don't know if you guys have read my book or not, but 11 times, 4 interviews, and I found the formula, if you want to call it, on how you can guarantee and secure a role. What methods, what approach do you need to take? How do you write your personal statements? And, how do you prepare for the interviews? What do you need to consider? And so on and so forth. To the point that the reason why I wrote the book was the ultimate guide to. I think I've sent most of you the summary guide, the PDF. I think I sent it over to you guys either on email or on LinkedIn. If you haven't, let me know. I could send that over. But that is a very strong guide, and I wrote that based on my experience and the experience I've had with other people. During my training, I helped six clinical support workers secure a role in my last service. Actually, no, not my last service, but in my last service and in other services. So they all secured roles, whether in the service I was in or in other services. And that's just six in the service. And I had about 3 to 4 out in London and outside of London. I had 2 people who secured 2 roles. So the way I helped them was I coached them on how to write their personal statements, help them in that. So I assisted them in that, and also in preparing for interviews. And I've been doing it for other couple of people, and I'm happy to hear that I think just over 15 people have succeeded over the last 2 years in securing the role. There's someone who's close to securing a role. We're just waiting for her to get her final results because she had an interview about a week ago. But anyway, um, that's about me. I'd like to know a bit about you guys as well. Um, I don't know if I could just get a moment. Can I just get an understanding of where people are, like what your roles and what are you hoping to maybe, what got you interested in joining this presentation? Yeah, go for it.
Hi, my name's Ambrin. So I'm currently working at the University of Hertfordshire as just a home admissions administrator. So I graduated in psychology with counselling skills 3 years ago, and I did a placement year as well for a year. And I worked at a youth charity organisation. So before getting into that role, I did apply for a psychological wellbeing practitioner. So I did go for an interview back then. But because it was my first ever time, I didn't know what to expect. So it didn't really go well, and I got really nervous in the interview. Um, so that didn't happen. But since graduating, I've just been really struggling to get myself into any sort of psychology role. Um, but at the back of my head, I've always kind of wanted to go into psychological wellbeing practicing. So when I saw this opportunity, I thought, you know, it's maybe a sign. So I just went for it.
Thank you for joining. And I think a lot of people can resonate with your experience because, firstly, there's not much information. When I came across the PWP role back in 2017, it was still a bit new, although the role itself has been going on since the training. When did they start? The first ever training, I believe, was in, I think, '06, 2006, 7, 8. That was when it was introduced back then, the idea of talking therapies, or back then IAPT, improved access for psychological therapies. 2006, 7, and 8, and I think 7 and 8 were like the first couple of like years where they were trialing the program. And the idea was that they wanted to split CBT into two levels: low intensity, mild to moderate cases, and then high intensity, moderate to severe cases. Even though the reality is, as a PWP, we do get complex cases. Sometimes they're severe and we feel like, okay, what's going on? But the idea is that it really depends on the scoring, engagement. There's a lot of things that they take into consideration. Um, but the idea is that back then in 2017, there wasn't much information. I could not access a lot of information. Maybe NHS careers, prospects, you get a feel, there was a video, but you don't get information or any resources on there's not a lot of resources or information about how do you apply, what do you need to consider. There were very minimal videos going around at the time. There's a friend of mine actually, he started something called Psychologist. If you can go on YouTube, he's done so many videos. He's stopped now, but he's done a lot of videos. He's been helping so many people like ourselves in the field of psychology, just trying to move forward, whether it's applying for an AP role, assistant psychologist, or a support worker, or the doctorate, whichever doctorate. And he's written, he had a website. Every week you're getting like 2, 3 blogs written by him, written by other people. Then he had videos, and I remember he had at least 2, 3 videos about the PWP. He never applied for it, but he's just giving tips based on his understanding, and he's collected information from people that some of the people that he knows have successfully applied to the role. But again, not a lot of this information. This is one of the reasons why I basically wrote the book, is because that information is not available. It's the only thing you'll find in detail. Um, can I share something with you guys? Actually, someone was asking about the PWP on LinkedIn, like where can I get access to information? I just shared, I said, if you want, I've written a book on this. I had someone say, no, don't buy any books, don't buy any books. And I felt like, okay, I don't know what's wrong. But he gave a lot of information. But the thing is, that information will not give you, that information will tell you what you can put in. But can we get an example of what does a personal statement, a successful personal statement looks like? Can we get an example of it? I provide you 3 examples in that book. I don't know if I have in the summary guide. I hope I have, just to give you an idea. And in detail, in depth information about the interview and what are the likelihood questions that are going to come. But we'll touch on that. Anybody else wants to contribute? What are you hoping to look for in this presentation, and what's your role, and what about the PWP that you like?
So I'm in a similar situation as her. I just finished my master's in psychology conversion course from
Yeah.
Hertfordshire University as well. And right now I'm just volunteering with a charity and just working part time to help my finances. But I volunteer with Mind right now. And I'm
Very
also in
good.
a similar situation where it's like I would meet all the criteria for like an AP job, but I would still get rejections for them, and I only get feedbacks every once in a while, and they say somebody has just more experience, and it's like, and I'm curious about what that experience is that's setting them aside, like they're favoring them more. And what I wanted out of this to one was like learn about what's a good personal statement, what do they expect from these things, and what are they looking from a candidate, and how you can sort of set yourself apart when applying for these roles, and just get as much information as I can about these things.
Brilliant. Brilliant. All right, definitely. Remind me, I will need you. I'll send you the there's a summary guide that I have. I'll send you that. It's available on LinkedIn, but I'll send it to you as well so that you can have that accessible. So our agenda today is, yeah, not a problem at all. Our agenda today is expectations of the role. What is the role? We'll touch on what does a PWP do? What are your transferable skills? These are important things. The skills, I'm positive all of you here have transferable skills. Maybe you graduated 3 years ago, 2 years ago, a year ago, or maybe a little bit longer than that. But I'm positive with, you know, your degree alongside and coupled with whatever experience that you have at this moment, you do have transferable skills. And we'll have a look at that. But these are the transferable skills that you need to bring with you to this role. We'll get an idea of what step 2 interventions look like so that you guys have an understanding and have a feel. What does the application process look like? Bear in mind, I am speaking mainly about London. However, do let me know if some of you are coming from outside of London and, it might differ, but it's good to know. And then possibly like, what are the next steps? What's the development or the career pathway or the career routes after graduating as a PWP? What else can you do? So before I get on to kind of like life as a trainee, which I'll give an example over here, but what are your expectations of the role? Like, what do you think the role's about, if I may ask?
Well, I'm assuming it's helping, like utilizing CBT formulation and frameworks and working with service users and how they can implement and like find coping skills with their struggles.
Very good, very good. Anyone else?
I think, as you mentioned before, it's about using low intensive CBD skills, and that's more self-guided. And I've also heard that the caseload for these roles are pretty intensive. So yeah.
They are intense. Yeah, they're challenging. Although they do differ service to service. Some services are higher, some services are lower. Frankly speaking, the whole NHS Talking Therapies actually are working towards getting services to start reducing them. It's challenging because each service has different demands. So, depending on the size of when we say a service, we're talking about a borough. The borough might be a large borough. The borough might be a borough where there's loads of demands. There's so many things going on. You could have a borough that has these problems and that problems, and it's just trying to cater to as much as they can. Although there will always be limitations. We can't deal with everything. But it is quite challenging, but it is doable. Nevertheless, it is doable. It is doable. I think what I would recommend always to people is, finding ways to really take self-care into huge consideration. Finding ways for you to psychologically detach, to not allow that to impact your off-duty hours, your weekends, and etc. But there are ways to manage it. There are ways to manage it. Anyone else? Can we get one more person? What are your expectations of the role?
So I think from what I read, maybe dealing with like mild to moderate cases around issues such as anxiety or depression, or eating disorders, issues around that.
Depression, anxiety, yes. Eating disorders, not at step 2. What's interesting actually is that usually talking therapies wouldn't deal with eating disorders. However, recently I've seen this on NHS Jobs, Track, and on LinkedIn as well. They're actually there's training now for CBT, but at high intensity. So eating disorders would be more or less at a high intensity level, but they are providing training for that. So CBT, high intensity, but specifically for eating disorders. And I don't know, I'm not too sure if those at high intensity, after they qualify, I don't know if this is an add-on or additional training that they have to take, but I'm seeing that that training is starting to be provided, but not at step 2. Not at step 2. They're quite complex. Right. So, what does life as a trainee look like? I'm just giving you guys here an example of a UCL trainee. When I was training, we had an intensive block, and our intensive block consisted of being at uni for 2 days. 3 days in the service, 2 days at uni, or 2 days training or teaching, if you want to call it. Now, I think since February, they've now added on a sort of like 3 days a week, but this is the intensive teaching block. So it's about 2 or 3 days. So it depends from training provider. It depends from this university to that university, but it's about, you spend about, I think it's 6 to 8 weeks, an intensive teaching block. So it's intensive. You're doing 2 to 3 days at uni, so teaching, and what they're trying to do is to make sure that by the end, you know how to assess and you've got an idea on how to start treatment. And we'll touch on what things are, assessment and treatment. And then you've got, teaching includes learning about interpersonal skills. I forgot to add engagement, and this is key and this is core to the work that we do, engagement. We're trying to make sure that our clients or patients, I prefer to use clients, we can say patients as well. What we want is to make sure that they're engaging in treatment. We need to work on engagement. How can we keep them engaged? They're going to have struggles. They're going to have difficulties. There's going to be obstacles. There's going to be so many things getting in their way, from doing tasks, doing homework, attending, feeling like treatment is working. How do we keep them engaged? And a lot of that comes from therapeutic skills or interpersonal skills. And it also comes from using the behavior change models, which we'll touch on, one of them being COM-B, which is a model that is used for behavior change. And that's the main one that has been deployed and that is sort of, used in the actual training. Then there's risk. So we do a lot of risk assessment. So we assess risk, we assess safety, highly considered, is taken into high consideration. We need to really always consider risk. We assess, we diagnose. Our diagnosis, by the way, is, we're not trying to give them an official diagnosis, but we are giving some sort of a provisional diagnosis. So getting them to understand what is the main problem, what we call a problem descriptor. So a problem description. And we can touch on that. That's quite an interesting one. So for example, one thing that we use when it comes to diagnosis is we sometimes would say depression, or we'd say low mood, because sometimes depression is a very heavy word. It's got a lot of weight to it. So we could sometimes use low mood instead. It's all right. We can allow clients or patients to even express, if they feel, sometimes they might agree, yes, I feel like I'm depressed, or I feel like I'm experiencing depression. Others might prefer, I'd rather go with low mood. It's like with anxiety, you've got generalized anxiety or excessive worry. And then there's treatment. So these are the things that we're learning. Then there's these regular assessments, including tutor observed role plays. So you'll have a chance to do role plays with another, fellow, trainee in your cohort. you'll have a chance to do a role play maybe with a tutor, and then you'll get a chance to kind of like get their feedback and etc. Then there's something called the OSCEs, which is sort of like this is where you're going to be sort of examined on how do you deliver an assessment. It's like an assessment exam. So they'll prepare you for that, where they'll get you to do role plays, and then you'll be assessed. This is actually one of the first assessments at UCL, at least. This is one of the first assessments. For some universities, some trainings, this kind of like assessment might come later. So it might come like 3-4 months down the line, whereas in UCL and others, it might come in the first month or two. So it's one of the first kind of like assessments. And then after that, you have, at UCL at least, you've got 3 different essays, what we call reflective accounts. These reflective accounts are 3 different essays. So what they look like, they're split into 3. The first one is about 1,000 words, the second is 2,000 words, and the third is 3,000 words. The first 1,000 words, the first reflective, what we call, the reflective account 1, or they call the RA1, that is based on your reflections on, your assessment. What can you do? They use a reflective model called the now. They call it the what, so what, and the now what's. It's like a reflective model that they use. What did you learn from your assessment? What can you do better, and etc. etc. The next one, 2,000 word, that's going to be your treatment. So you're going to do a recording of your treatment, and then you need to reflect on your treatment. What went well, what didn't go well, and what can you do better? And then the third one is using a case and using supervision. So based on a particular case that you worked with, a client you worked with, how did you benefit from supervision? And that's going to be the final one. And then after that, you've got a presentation, you have a written exam, and you've got something called a practice outcome portfolio, which is a long portfolio of things that you need to complete. Some of them call it clinical outcomes. At UCL, they call it practice outcomes. They call it different things at different universities. So yeah, just kind of skipping on all of these stuff. But like I'm just saying that what you'll have assessments. They can be summative or formative. Summative are usually the ones that are marked. You've got these specific practice-based learning, what they call a PBL day. These are allocated time for you to prepare for assessments, to prepare for exams. So these are like days where you're not at the service, but then you're not going to be at uni. You're meant to kind of just use these days to kind of like either study or to be working on one of your assignments or your assessments or one of your essays and etc. or preparing for an exam. Non-uni days, spending the service, and what you're doing throughout the years, you're gradually building up your appointments, or you're building up your contacts, your target, your caseload. There is a trainee caseload, which is not meant to be the same as a qualified caseload. Every service will let you know. And you have weekly supervision, which should take about an hour and a half clinical supervision every week. Usually how that works is the first hour is meant to be case management, and the second part, the additional half an hour is meant to be for clinical skills with your supervisor. Does that make sense so far? I hope that was not too long, but does that give you guys a rough understanding of what a life like a trainee might look like?
Yeah.
Wonderful. A week in the life of a PWP. So as I mentioned, you're doing so many things. You've got a lot going on your plate. You've got uni, you've got clinical work, and that's a question that's going to be asked in the interview. What is your work-life balance like? Are you able to balance academic work with clinical work? So your training is based on academic work and clinical work. Can you balance both demands? Because what you're going to be doing is you're going to be doing assessments and triage. Now, it differs from service to service. So my previous service, for example, they have triage as the first point of contact, what we call a telephone triage, a TT, then a problem-focused assessment, a PFA. I apologize. I know there's a lot of acronyms, so do bear with me. Even I get confused. But what I'm trying to say is that there's a triage, a telephone triage. Usually most services, that's the first point of contact. How it works is like this. Client refers themselves to the service, whether through their GP or an online self-referral. They refer themselves, complete the form. Now it goes onto the system. A couple of weeks later, well, for some services, it's actually within a week, they get booked in for the first assessment. Others, they might wait a week or 2 weeks and then they get booked in, or they get booked in 2 weeks. So it's usually quite quick. And then that's the first point of contact, the triage, which is a 30-minute, roughly it's about 30 minutes. It can go up to about, I don't know if I mentioned it here. No, I didn't. Hold on. Yeah, I mentioned it here, something like that. Anyway, it's like a 30-minute assessment. You're just trying to gather some information. What you're trying to do here is, after you've done the whole confidentiality, introduce yourself in the role, and they've introduced themselves and etc., and you've got a couple of that information, confidentiality. Now what you're trying to gather is, you get their scores, get an understanding, allow them to reflect on what their scores are. What scores? The PHQ-9, Patient Health Questionnaire, and that's to see where they are in the depression scale. And then we use the GAD-7 for the anxiety scale to see where they are. Do their scores reflect how they feel? Yes, no. All right, we'll get into more detail. Then you look at risk and safety, so you assess all of that. With risk, what you're mainly assessing is risk to self, risk to others, and that's based on the question that says in question 9, thoughts that you'd be better off dead or of hurting yourself in some way. They've got 4 options, which is either not at all, which is 0, 1, several days, 2, more than half the days, or 3, nearly every day. I'll be honest, I think this needs to be revised because it's quite an old questionnaire. I mean, was developed many years ago. It's useful, but I would say sometimes do think about different ways you can kind of explain that to them, because not everybody might understand that. But anyway, based on that, you look at risk of self, risk to others. Then you look at other things like sort of like safeguarding issues about children, about alcohol, about drugs, about nicotine, vape. That's something we do even ask as well. You look into risk to self. We're looking at suicide. We're looking at self-harm. We're looking at, are they a risk to others? Are they a risk from others or risk to others, and etc.? We're looking at so many different areas of risk just to make sure that we are taking everything into consideration. Anyway, that's in about 30 minutes. Sometimes it goes up to 45 if needed, because sometimes we do interpreter work where we do need an interpreter. Like, for example, there's 2 ways of doing interpreter work. One way of doing interpreter work is, for example, I speak another language like Arabic. I might, need a bit more time if I'm doing an assessment with someone who's Arabic speaking. I'm assuming that many of you, do speak another language, so you might be able to do it in another language. If we have another way of interpreter work is, in a language that we don't speak, we need to now hire an interpreter, and we have them with us in the call. And because we might take a bit of time when it comes to asking questions, and the interpretation can take a bit of time, that might need a bit of an hour for that. But anyway, in the new service that I'm in, they don't do the triage. What they do is an assessment, what they call an initial assessment. And that's literally the telephone. It's kind of like the telephone and problem focus kind of combined, which is something that I'm learning at the moment. Then we move on to treatment. So after the assessments, by the way, if any of you, for any reason, need to leave, don't hesitate to let me know. But this will be recorded and you will get access to it. After they're assessed, what we're trying to look at in the assessment is, once we've looked at, the risk, then we look at the problem. What is the main problem? What got them to reach out to the service? Getting an understanding of that, the problem. How has the problem impacted them? How has it impacted their sleep, their appetite? How has it impacted, like their hobbies? Have they found that they're not engaging in their hobbies? So like a question I might ask is, do you feel like you're engaging in your hobbies? Do you feel like you're minimally engaged or you're less engaged? Has it impacted them at work, school, uni? Has it impacted them in terms of their routine, their day-to-day activity? Has it impacted them in their social lives? Like, do they feel sociable, minimally sociable, or less sociable with family and friends, and so on? And then after that, we look at, have they ever experienced any mental health problems in the past? Yes or no? And if they have, what were they? How long ago? Have they ever received treatment? Perhaps they did receive treatment, maybe at Talking Therapies. If not at your service, maybe at another service. Maybe they moved boroughs. Maybe they received it many moons ago. Maybe they had it at a different service. So maybe not at a maybe not at a Talking Therapy service or an IAP service, but maybe at perhaps at a different service, different NHS, so on and so forth. So we're just trying to get an understanding, have they had any mental health treatment before? What do they want to focus on? And most importantly, what are their goals? Can we set some smart and clear goals that are specific, they're smart, and that show that the goals help us to understand what this person is looking for, whether or not can they, can the service provide them with treatment? Or do we need to refer and signpost? In the case of treatment, at step 2, so if it's step 3 or counseling or anything like that, then that's something you have to discuss with a supervisor or what they call a referral manager. But at treatment at step 2, we've got these three things. We've got the guided self-help, the one-to-one work, could be face-to-face. One-to-one basically means it's you and someone else. It could be face-to-face, could be over the phone, or it could be over Microsoft Teams. And there's groups or workshops. So now we do a bit of group work. Then there's CCBT, computerized CBT or online CBT, also known as Silver Cloud, the platform that the majority of us use. Guided self-help is about 30 minutes. Sometimes it can go up to 35 or 40, depends. You might find that sometimes you need to make adaptations. Groups are usually about 90 minutes, that's about an hour and a half. Silver Cloud, well, you've got about 30 minutes, 20 to 30 minutes for the intro call. So you're introducing them to what Silver Cloud is and how you're going to help them and etc. And then about maybe 15 minutes per review. A review could be online, a written review. This is where you get your writing skills, learn how to it's literally learning through writing. How do you deliver therapy and how can you engage your clients through writing? It takes time, but I find it amazing. Or telephone. Sometimes your reviews can be over the phone, just checking in and seeing how they're getting on with the program. There'll be a mix of remote work as well as working in sites, clinics, and offices. Prior to COVID, I don't think there was a lot of remote work, but after COVID, there are a lot of services. I would say the overwhelming majority of services are starting to see that hybrid working is the way forward. And hybrid working can depend. For some services, it's maybe working from home once a week, or twice, or 3 times. Most services, based on my understanding, it's either twice or 3 times a week working remotely, and you're in the offices, sites, or clinics either twice or 3 times a week, depends. But a lot of them are adapting to the more hybrid approach, which is allowing everyone to feel that there is a level of flexibility, because the workforce is everybody's got, either family, you've got single parents, you've got childcare, you've got, taking care of the elderly, you've got so many things going on, but it is, or has been shown so far to promote flexibility. And obviously staff well-being is taken into consideration. And then obviously your non-clinical work includes diary management. So you're managing your diary, your weekly diary, preparing for sessions, attending meetings. You've got different meetings throughout the week, throughout the month. Emails and admins. That's a lot of time, a lot of work. Referrals, you're making referrals left, right, and center. You've got supervision. That's on a weekly basis. And then you've got clinical skills, which is usually every fortnight. Does this make sense to everyone?
Yeah.
Brilliant. Step 2, interventions. I'm going to give you guys a bit of detail. And before I do, what do you know so far? What do you know about step 2? What have you read? What have you heard?
Well, I would assume step 2 would be low interventions, and like higher up would be high interventions. So like I'm not well versed with the steps, but I would assume step 3 or 4 would be like a high intervention treatment. And maybe step 1 could be like primary care service, like GPs or like teachers, maybe.
It sounds like you've done your research in terms of the step care model, which is good. Exactly. Step one is basically GP level. They do a little bit of psychoeducation from there at their level. But step two, what do you guys, I mean, if you can give me an example, like what do you think is treated at step two? Like what's the intervention used? Does anyone have any idea, anything in mind?
If the clients show with has concerns about like low mood or depression, I guess this would be the stage where we would introduce behavioral activations and so like low intensive CBT.
That's exactly it. And we're gonna have a look at that at the moment. What I'm gonna do is I'm gonna skip this for now. Only one thing I'm gonna mention is the last part, the assessments. That's the only thing. I've already said the top part, already kind of given you guys. And by the way, I'll send you this presentation to all of you. I'll send you this presentation so you can have a look at it afterwards. I just wanted to mention, because I've already got each one bit of an outline ready for you guys to have a look at. So we'll touch on this bit by bit. But the last part here is just the assessment, the PFA, the problem focused assessment. The idea here is you're preparing them for treatment. So, like I said, services might differ, but say, for example, let's say I'll give you an example from my previous service. After the initial assessment, which was, the telephone assessment, the triage, if they're taken on board, if they're taken on for step two, guided self-help, for example, they'll be put onto the waiting list. And then they're going to be allocated to a practitioner. Practitioner now contacts them, books them in for the first appointment. And that first appointment is meant to be the second, what we call the second assessment, or the PFA, the problem focused assessment, similar to the triage, but here it's more focused. So it's preparing them for treatment by assessing them and at the end, formulating a problem summary statement and goals. Using the COMBI model, which basically means that behavior is based on three factors, or behavior can be achieved through three factors. C is for capability. Are you capable of doing it? O is for opportunity. Are there going to be any physiological or psychological sort of like barriers or challenges? Do you have the opportunity to do so? Will there be any challenges or anything getting in the way? And M stands for motivation. So capability, opportunity, and motivation. Are you capable? Is there anything going to get in the way? And out of 10, how motivated do you feel that you can give this a go? That's COMBI. And this is key because this is a model for behavior change that was developed by Professor Susan Michi, who is actually one of the professors at UCL. She's not part of the program, but this model is now used in so many different coaching settings. And in particular, by the way, the reason why I said coaching setting is because the PWP is basically you're a therapist and you're also a coach. You're kind of both, because it is quite interesting because you're kind of doing a bit of like coaching and therapy at the same given time. But anyway, but you're using that to assess their readiness to treatment. Are they capable? And I've given you guys some examples here. Are they capable of attending 6 weekly sessions? Will there be any barriers getting in their way? And how motivated are they out of 10 to give it a go, to go ahead with it? These are the things we're trying to assess. We're also trying to assess not only are they willing to attend 6 weekly sessions. In these sessions, are they willing to have tasks or in between session tasks, basically homework? What do they think might get in the way from attending, engaging, and making it until the end? So we're really trying to look at engagement, or assess the readiness to engage. Let's have a look. We've got behavioral activation for depression. We've got worry management for GAD. We've got grade exposure for panic and phobia. We've got stress. We've got cognitive restructuring. We've got sleep. And finally, ERP, which has recently been introduced. This was introduced last year. ERP, which stands for Exposure Response Prevention for OCD, at step 2. So OCD now, based on the new curriculum, is going to be treated at step 2, but at a step 2 level, which is using ERP. We're not going to touch on the thoughts. And I'm fortunate that I've had someone to work with, because we only had the training. When did we have the training? In June, July. I've had one client so far, and it went well. Went really, really well. I learned a lot from it. Behavioral activation for depression. So the idea is at step 2, what we're trying to say is we start with behavior change before cognitive change. Starting with behavior change before cognitive change. Why do you think that's the case? Why do you think we're going to start with behavior before thoughts? Why can't we just go straight to thoughts? It's a question to everyone. So
Could it be because solely focusing on thoughts, it's hard for them to feel validated that what is the right thought without having some form of external validation to support this is the right approach to having like why these are negative thoughts and how they are like impacting your life negatively, and that behavior can actually help them reminded in some way.
it's a very good answer. It's a very good answer. Very good answer. That's a very good answer. Anyone else? I like that answer, by the way. That's a really good one. Anyone else wants to add? No one? All right. Behavior. The reason why is because a lot of times thoughts are, they can be dealt with. But with behavior, once we start making behavior changes, thoughts will naturally change as well. When they see a client, so when clients see that they are able to now do things. So behavioral activation says, in order for us, so this is the outside-in approach, which basically says, this is how I actually put it. In order for us to do something, we actually need to do it. But what happens is that our mood tells us not to do it. So the outside-in approach is the outside, the things that we do. When we exert effort to do something, it then has an impact on how we feel. So some people say, I'm not motivated yet to go for a jog. I'm not motivated yet to go to the gym. So that's an inside-out approach, which basically means I need to wait, I need to become motivated in order for me to go to the gym, or to go for a jog, or to go for a walk, etc. Behavioral activation does the opposite. It takes the opposite approach, which is the outside-in approach. Note, by putting in the effort, i.e., by sticking to the plan or by following the plan, not the mood, will I able to build on that motivation. So if I can do things in a gradual manner at my own pace, which is what behavioral activation says, doing things at your own pace in a gradual manner. We're using a graded hierarchy, we're using a graded difficulty hierarchy. Basically, we're starting with, you've got the easiest, the least difficult, the medium, and the hardest, the most difficult. Just start with the easiest, building those building blocks. For example, a person says, I want to do push-ups. All right, how many push-ups do you want? I want to do 50 push-ups. Very good. That's a really high, it's a high goal. All right, but then the person struggles to do even 10. All right, fair enough. What did you learn from that? Okay, maybe I need to lower my expectation. What's easier for you? You know what? Let me start with 5. But 5 feels and sounds so low. All right, but as you build on that 5, you will now start to get used to it. You will naturally feel like you want to do another 5. So that 5 has now gone to a 10. then naturally you want to do another 10 or another 5. So it's gone from 10 to either 15 or 20, and that continues so long as there's consistency. So it's starting with the easiest, but by doing things, you start to feel better. Let me give you guys one more example, if I may. Naturally, how do we feel when we're ill? Generally, when we're ill, we've got a cough, we've got a cold, we've got a headache. We, first of all, our appetite drops. Naturally, whoever is ill, you rarely find a person who's ill and they've got a high appetite. Our appetite immediately drops. It's natural. Maybe some people might be an exception. However, when you're ill, you feel like your appetite drops. So you've got a low appetite. You actually don't feel like getting out of bed. You don't feel like getting out of your room. You actually don't feel like doing anything at all. How do you feel if you were just to walk out and just step outside of your house and get some fresh air? What would it be like if you just went to the shops and back? I don't know, you just went to the closest shop, you went to, I don't know, the local Tesco's, local Sainsbury's, wherever it may be. How would you just feel just going there and back? Even if you didn't go in, just going there or just going close to it and then coming back home. How do you feel after doing something and then coming back? It changes. So by doing, it can change how we feel, and it can change as well as our mindsets, our thoughts. But later on, what we see is that when thoughts are still maintained, or thoughts are still maintaining the mood, you still feel like, okay, I'm putting in the effort, I'm doing stuff, but I still have my thoughts are still disturbing me. That's when we can start doing a bit of cognitive work. Does that make sense, everyone, about the answer? Sounds like it's clear so far. So with behavioral activation, 6 sessions. Session number 1, at every session, you're going to see we have psychoeducation. So we've got psychoeducation, we've got the 5 areas, which is the vicious cycle, and then we introduce a particular diary. Actually, hold on. I didn't add the panic diary there. Okay, that's fine. I do need to make that change. But anyway, we need to, so what we're doing at session 1 is psychoeducation. We get them to understand what is depression, what is low mood, what is the 5 areas. We get them to understand the vicious cycle. This is where you are, these are the thoughts you're having. This is how you feel emotionally, this is how you feel physically, and these, as a behavior, this is what you end up doing, and you're going on this circle. This is a merry-go-round. Yeah, you're on the London Eye. You're literally going round and round and round and round, and you're asking them the question: does this resonate? Does this make sense to you? Majority will say, you know what, that actually sounds just me. So I am going around and round and round. This is where you are. You're in this cycle. What we want to do using behavioral activation is to break that cycle. We want to break that cycle and help you to start doing things, because you're not doing things. And because you're not doing things, you're now coming down this downward spiral, being pulled down. And this downward spiral is basically low mood avoidance, low mood avoidance, low mood, I'm not doing anything, low mood avoidance, putting it down the dark rabbit hole. And then what you do is you introduce the baseline diary to them. What is the baseline diary? It's just a diary basically from Monday to Friday. So Monday to Sunday. It's a diary letting them know what are they doing throughout the week. Every single day, what are you doing in the morning, afternoon, and evening? It doesn't have to be in full detail, but it's just giving an understanding and an idea. You're getting an idea, hopefully for the next session, what are they doing? And it allows them to see what they're doing. And then in the next session, session 2, we identify a couple of things. What are your routine activities? What are your pleasurable activities? What are your necessary activities? Routine, what do you do on a regular basis? Such as shopping, I don't know, skincare, going to the gym, going for a walk. Although they do overlap, some of them can be, some routine can be considered pleasurable, that can be considered necessary. Pleasurable, what do you like to do? What do you like to enjoy? For many people, there's so many different things. Sometimes going to the gym is pleasurable. Sometimes going for a walk, socializing with friends, that's something pleasurable. Some people like video games, whatever it may be. Necessary, you've got necessary activities, the activities whereby if you don't, these are important activities, essential activities, whereby if you don't do them, there's going to be negative consequences. Paying your phone bill, MOT if you've got a car, insurance, rent and bills, food shopping, sometimes, certain issues like skincare and hygiene can even fall under necessary. That depends. Some people consider routine, some people consider it to be necessary. And what you're trying to get them to understand is we're trying to establish something called the RMP balance. RMP basically stands for routine, necessary, and pleasurable. It's a balance. If we imagine a three-legged stool, and each leg represents one of these three different activities, we want to make sure that they're balanced. So getting them to understand what exactly is a balance. If I'm going a bit quick, it's only because of time, and I don't want to, take too long. But anyway, that's what you're doing, and then you're ranking activities by difficulty level at this, third session. I actually do that in the second, but you could do that at the third. Take it one bit at a time with them. So you want to get them to do it bit by bit. Ranking difficulties by level. So, taking in a gradual approach to becoming more active. So what we mean by the levels are, like I said, easiest, least difficult, medium difficult, and most difficult or the hardest. And then in sessions 4 and 5, all you're doing is you're doing activity scheduling, planning how to overcome the feeling of demotivated. A lot of it's just reviewing, and usually sessions 3, 4, and 5, this is where you're doing a lot of engagement. Actually, you're doing engagement throughout, but 3, 4, and 5, you can now see what's helping. Are they managing? Are there any obstacles? There will always be obstacles. What are these obstacles? Talk about them. Let's talk about these obstacles. Let's troubleshoot. Let's review their progress. If they've written their their promise summary statement and goals, you get a chance to review, where are they? We wrote this a couple of weeks back. Where are you today with them? Have you noticed anything different about them? Yes and no, and what's been helping? And then finally, the staying well plan, planning to manage setbacks, reflecting on progress. So that's with behavioral activation. It's almost the same thing with every one of them. So I've got all of these sort of, structured out for you guys. So with worry management, you're just teaching them about worry, introducing the worry diary, distinguishing between the two different worries. What's a practical worry and what is a hypothetical worry? Practical worry, I can solve it now. Practical, hypothetical worry, I can't solve it. I can't control it. I can't do anything about it. All right. So now that we've done that, what do we do with a practical worry? We do some problem solving. What do we do with hypothetical worries? We do something called letting them go using worry time. You can have a look at this. I'm only rushing just because of time, so I don't want to keep you guys because there's other stuff I want to cover. Gradient exposure for panic and phobia is basically exposure work. It's teaching them, firstly, in the psychoeducation, you're teaching them about the fight or flight response. It's normal. It's part of our human reaction that when we're faced with danger, this is how we react. We teach them all about the fight or flight response. We introduce to them what is avoidance and how panic and phobia play a role in avoidance, meaning avoidance as a behavior. We're just avoiding people, places, objects, and etc. and situations. And then we also introduce the idea of habituation, which is the exposure and remaining in that exposure until that panic, that anxiety, that fear, phobia starts to drop, and not avoiding that situation. So that's what we're trying to teach them and get them to actually start doing. Can you now see all of this is behavioral work? And what you're doing with panic and phobia using graded exposure, you're just teaching them about what are feared situations. Can we, what are your feared situations? Let's write a list. We're going to do a graded hierarchy. What are your least feared situations, medium feared, and your most feared situations? Get an idea what they are. Rank them even by percentage. And then we're trying to get them to understand in order to meet habituation and exposure, it's important to consider 4 different principles, which are basically that it's graded, your exposure is graded. You have to prolong it. You need to repeat it as many times as possible. And finally, you need to remove all types of distractions. It can help when you have someone with you, but you need to decrease that as much as possible, not to rely on them. But if you have someone with you, kind of like, let's say I had a client, for example, who said, I'm going to go have dinner with someone, with a family, and I don't want to go on my own, I want to go with my daughter. And I'm like, that's fine. Like if that helps at the start, but then other exposures, you need to kind of reduce that dependency so that you can become more confident. As you're climbing up that hierarchy, you're building not only your comfort, but you're building confidence. You actually feel like you're becoming more confident and you want to do more and you want to climb higher. So that's basically it. It's about helping them to move forward, overcome the problem, and feel that they can manage it. Self-management. With stress, you're teaching them a bunch of different stress management techniques. Fortunately, Camden, and I think other services even outside London, but Camden and Islington, they recently this year they've got new material that they've published. Depression, low mood, they've got panic and phobia, and they've got one for stress and worry, which is a lot of us are using for stress management. It's very, very helpful. So again, psychoeducation, 5 areas, introduce the stress diary to them, and then you talk about stress demands, the balance. You can talk to them about the routine, necessary, and pleasurable balance that's used in BA. And then we have something called the stress bucket tool. Has anyone heard of the stress bucket here? Anyone ever come across the stress bucket? One of the best tools for stress management.
Yeah, I've used it a lot with while I work with mine, is just helping people understand how their stress can slowly build up and how they need to release it.
Very good, very good. So some of you guys have some understanding of it, and it's really good. It's very, very effective. I usually bring that up in the second session, and that's just to get them to understand that there's an effective way for them to de-stress themselves, if we can call it that. Then we teach them a bunch of other techniques. Sometimes it depends. You got to be a bit flexible. It's a bit blended. Like it really depends on what the problem is, and we're trying to it's kind of like a set of tools, pick and choose, and it differs from person to person. So you got like stuff like problem solving, worry time, letting go, time management, relaxation, thought challenging. That's something we work on. And then we're just reviewing their progress as much as possible. Cognitive restructuring. So now we get onto the cognitive side of things, which is basically just teaching them how to challenge their thoughts. But what we're trying to understand is, again, with psychoeducation, what are negative thoughts? How do they affect us? It's important to distinguish between a negative thought and a worry. So worries and negative thoughts are two separate things. It's important to distinguish them. We introduce the thought diary to them, and then we start, getting them to put the ideas of the diary. The point of having these different diaries, I didn't mention this earlier, but even with panic in this first session, we need to introduce something called the panic diary. The point about all these different diaries is to monitor what's going on. Monitor what's going on in that diary. If it's a thought diary, what are their thoughts? If it's a stress diary, what's stressing them? What are their thoughts? What's their behaviors, and etc. If it's a panic diary, what's going on in that panic? What's the situation? And etc. So what we're trying to teach them here is how to identify, how to start spotting or noticing negative thoughts. How do we then label them? How do we label the thoughts? So, what is the cognitive bias from these thoughts, or the thinking trap, or the unhelpful thinking, getting them to label it and, understand what this is. Is it all or nothing thinking? Is it black or white thinking? Is it jumping to conclusions? Is it mind reading, and so on? So getting them to understand what thinking traps are they falling into. And then after that, we get them to practice challenging their thoughts, evidence for and against, and then formulating alternative or balanced, revised thoughts, and noticing how thought challenging can really help them see things differently. A thought is just a thought. Sleep is something that not always, because we don't get many people with sleep. So with sleep, you might call it CBTI. This is when you have someone who, so the main problem is sleep. So they have insomnia, for example. And that is the main problem. It's not depression and they got sleep problem. It's not anxiety and they got sleep problems. It's not stress and they got sleep problems. It's not OCD and they got sleep problems. It's not panic and they got sleep problems. No, this is solely sleep. And this can be treated with, CBTI in 6 sessions. We can do it at guided self-help. It can even be done even on Silver Cloud. So, just touching on a couple of areas of sleep, you're doing a lot of education. You're introducing them to sort of like, you have to assess it. There's 2 different sort of treatments. I think one is called stimulus control and the other one's called sleep restriction. And then I think you have to choose one of them and then you just follow on from that. And then finally, ERP for OCD, which is basically teaching them about what OCD is, the cycle of OCD, an OCD diary, introduce the idea of what ERP is, and then from there we start, we talk about, how the compulsive, their thoughts, intrusive thoughts, compulsive behavior just keeps them in that cycle, introduce a graded hierarchy for them. It's similar to graded exposure for panic, but here it's in panic, panic and phobia, the difference between them, the difference between grade exposure, panic and phobias, and ERP for OCD is basically it's one of the conditions, which is basically the four principles. So in panic and phobia, the four principles are, like I said, graded. So graded here as well. And then there you've got graded, you've got prolonging it to meet habituation, the same thing here with OCD. Repeat it as many times as you can. So here as well, you need to repeat it. In panic and phobias, what you're doing is without distraction. Here with OCD, it's prevention response, meaning you're preventing yourself from compulsive behavior, meaning you're preventing yourself from falling into that compulsive behavior, whatever it may be. Does that make sense? The difference between exposure at work, panicophobia, and OCD in ERP. Does that make sense, everyone? Show of hands, anyone? So you learn this more. Hopefully, I hope you all get accepted for the training. But that's just the main difference. And obviously, like I said, you just keep moving them up the hierarchy, let them build their confidence, and then review, troubleshoot, and then you get to the staying well plan. I might skip this for now, but the only reason this is here is just in short, is basically, so here what you just need to think about is how will people engage in an online program where they don't get a lot of one-to-one work. Maybe you can adapt a bit of telephone work or telephone review, but it'd be mainly through an online platform. There's pros and cons to it. The benefit is that it has a lot of programs like social anxiety, OCD, LTC. They've got like LTC programs. They don't have any PTSD. There's no program for that, but they do have extra modules that can help. Stuff like grief, self-esteem, employment, core beliefs, which we don't touch. That's more of a high intensity step 3, but we touch with negative automatic thoughts on NATs, and they have some extra modules that can help with them. But yeah, you guys can read that later on. Let's touch on transferable skills. I don't think we're not too far from the end. I think we've got this, and I think the application and interview, and then we're almost done. Transferable skills. Okay, my question now is, what do you all think you can bring to the role? So what transferable skills do you think you can bring?
From my experience, one, being able to empathize with a lot of people's problems is one thing I can say about myself. Second is having strong, like, theoretical knowledge of everything. For me personally, I think the weakest would be therapeutic skills, actually. Like, yeah, that's the main thing I would say for myself.
Okay, that's good. Okay, anyone else want to add?
Like
Um,
time management.
Very good,
resiliency.
very good. Anything else? We'll get one more, and then I'll turn to the next page. Anybody want to add?
Communication skills.
Communication skills, exactly. Now, these are, I hope this is clear on your end, but these are the different skill set that you can bring in. So you've got, number one, awareness of common mental health problems. You have an awareness, you've probably worked with people who have, at whatever given capacity, and based on your experiences, awareness of common mental health problems, what they are, understanding them, knowledge of the step care model, So if you have some knowledge, if you don't, it's fine. I think it will help if you do have a basic knowledge of what step care model is and how does it look like. You can always Google and kind of read and research. Experiencing, you've got experience meeting targets. So that could be, just meeting targets in terms of, like caseload or whatever targets that you have in your current or previous experiences. Conducting assessments, whatever they may be. So you know how to conduct any form of an assessment. Administering clinical measures. This is basically using questionnaires, and explaining them. You know how to administer, you know how to use them, and you know how to explain the scores in layman, non-jargon, not using jargon language. Familiarity with signposting, which is important. You know how to signpost, you know what it is, and you have some experience signposting people when needed. Assessing and managing risk. You've done that before. Effectively using supervision. So you have had supervision. It doesn't have to be weekly, it could be monthly, but or bi-weekly, every fortnight, etc. But you've had it before and you know how to use supervision. You know how to apply the advice given to you. Maybe you've worked with interpreters. Okay, so if you haven't, it's fine. It's always a learning thing. Not everyone has, but if you have all of these experiences, it's a big bonus. So working with interpreters, delivering telephone appointments or telephone sessions and what have you, even if it be short or long, etc. High volume work or caseload management. You've dealt with a high volume caseload or whatever caseload that you've dealt with. You know how to manage a caseload, basically. Letter writing, so we're talking about emails, we're talking about writing letters, emails, referrals, etc. Collaborating with other services, so a lot of liaison work, communication skills, as you mentioned, time management, managing stress and building resilience. Now, as I mentioned earlier, as a trainee, generally the role you're going to have to you need resilience skills, you need to manage stress, but as a trainee, you're juggling between academic work and academic responsibilities, as well as clinical work and clinical responsibilities. So how do you manage that? And if you've done this before in your undergrad or your postgrad, maybe you've done a master's, and let's say you worked part-time and you were doing that full-time, or you were studying for part-time and you're working full-time. So there you go. You've managed. You've got that experience on your belt. And then balancing admin and clinical duties. How do you've got your clinical duties and you've got your admin duties. It can be a lot. How do you manage that? So a lot to ask. But does this all make sense? And do you guys resonate with any of these?
Yeah.
Brilliant, brilliant. Some things that you need to take into consideration. In terms of the application process, so I use this as an example, but I'm assuming that a lot of you are okay. How many of you are in London and how many of you are outside of London?
I'm outside of London.
Okay,
Outside.
that would be best. First of all, you're saving them time, and you can summarize yourself in a page if possible. Like if you go over beyond a page, they can still take you on board. It's just I always emphasize, if you can, try to make it a page if possible. What happened? Does that make sense so far? We'll get a chance to have some questions in a moment. We're almost done. I'm just touching on, we're in the last couple of slides. So interviews, what questions do you think they will ask? Does anyone have any thoughts? What questions do you think you'd get asked in an interview? I think some of you had some experience in the interviews. I'd like it if you could share that with us, if that's all right.
So what I remember from my interview, she asked me, why do you think you would be suitable for this role?
Okay. Very good. Anyone else?
I think they might ask questions about time management and any kind of like question that might give them insight into the how we organize our time.
I think I remember they sometimes ask scenario questions and what you might do in that situation.
By the way, with those scenario questions, they're actually real, and though most of them are actually real, they're like real stuff that happen in their services. Especially if it's coming from someone who's from a particular service, they'd bring something up from their service, and they just want to know, is this the person that we're looking for? Is this an ideal candidate for our service? Um, and those questions can differ. It could be a question about engagement. It could be a question about a particular client group. So, for example, a service has a lot of panic clients, so they might ask a question about panic. Or they might have questions around some of the diversity characteristics like LTC, long-term conditions, diversity, LGBT, older adult, young people, etc. So, for example, I was asked a question, I think this really helped. The last question I was asked in the service that I got into was about young people. How would you feel, how would you approach working with people from the ages of 18 to 25? And I answered that question, and I even looked at her. I saw her reaction. She was smiling, and I felt like, okay, I hope I did get that. And yeah, I heard from her a week later when she told me the news that I got it, and she said, you scored high, and I think that answer that she liked that answer because she was the one who's running the actual young people's group. Came to find out later on, but those questions are questions that they're trying to look out for, see whether or not you're an ideal candidate. Sorry, anyone else want to add what questions that they think might come up?
Would you ever get a role play?
It is possible. It is possible. Not every service, not every uni, but it is possible.
So I had my interview at one of the King's Cross hospitals. So I remember in as part of the interview, she left me in the room by myself for like I think 5 or 10 minutes, and I had like a paper, and there was like different not scenarios, but it was regarding different patients and what their problems were. So what I had to do was I had to like summarize it. Um, and she wanted to see how I would summarize it or something like that. Then they would send it off. Um, so I don't think I completed it properly because I had 10 minutes. So I think I was too busy trying to figure out how I would write it. But that was one of the things that I had to do.
10 minutes is short. That must have been a really
Yeah, and there was like five
difficult
or
moment.
six
Yeah.
scenarios of different patients and what each of their issues were. So I think I only managed to like summarize 3 and my time was up. So I don't think I did well in that part.
Yeah, you got put on the spot. That's a
Yeah.
tough one. I don't know what I would do in that one. Um, but yeah, role plays something like that. Yeah, would definitely is something that not everyone, but not all services and unis, but a lot of them, do tend to have a role play. And role plays differ. There are role plays around risk or dealing with a difficult client or dealing with someone who's struggling to engage, something like that. A role play could even be because my experience of role plays is not for the trainee role, but for the qualified role. I had a couple of role plays for that, and a lot of them, each service had a different sort of role play for me. Anyway, the interview process. Sorry. Number one, be familiar with the questions. I wrote there, see my guide on interview preparation. Has anyone looked at my guide? If yes, can you just tell me? Because that is a summary. I do have the book, and I will share with you a link to. If you guys, I don't know if anyone's bought my book, but if you guys would like, the book is available on Amazon, and there's the ebook of it is available on Gumroad. I just uploaded it a couple of days ago, and I'll send you guys the link if you guys want to have a look on in more depth. Because I've excluded role plays from the summary guide, but I put it in the actual book. But does the guide have interview preparation? Like, does it have a couple of questions there? Has anyone read the guide that I've sent, or the one that's available on LinkedIn? Okay, I don't know if anyone
I
has
haven't
had it.
had the chance to read it yet.
No, that's all right. That's all right. I think I've got it in there because that summary guide must have had it. Yeah, I do have. You can have a look at the interview preparation section. Um, I'm just checking it very quick.
Yeah, there's a few questions on there.
Oh, you can see it.
Yeah, yeah.
So I think I've got a few questions there. All right. I think it was it downloads summary guide. So on that page, I'm just having a look. I think it's somewhere. Yeah. All right. So that's page 22. So you've got some questions there. So I've given you guys over here some example questions, and the idea of what I tried to do was to make sure that I split them based on different categories. So you've got safeguarding a risk, you've got the engagement and interpersonal skills. So you've got some pointers to consider. So that's worth noting down. So do have a look at the things that you need to look into, pointers, things to consider, things to be aware of. There will always be a question on diversity, so that's usually the case, and it really depends on the service, themselves. So usually in an interview, you will have someone from certain services, or let's say it's the service that you selected. You know, whatever service that may be, there will be a question. Usually, there will be a question around diversity. And remember, diversity differs. It could be to do with culture, it could be to do with faith, religion, it could be to do with older adults, LGBT, could be to do with LTC, could be to do with perinatal, it could be to do with neurodiversity, could be neurodiversity is becoming big all over. So many different things. Questions on engagement, interpersonal skills, adaptations you need to make. LD, what did I write LD for? LD, learning difficulties, yes. Learning difficulties, ADHD, LTC, think of an example from your own experience. Think of an example from your own experience. I'm positive you guys have probably had in your own experience, you probably dealt with someone who had or is under, a particular characteristic of, a particular diverse characteristic. Excuse me. But like, how did you deal with them? Did you make any adaptations in the way you dealt with them, the way you managed with, the way you managed them, and etc. There will be questions on modalities. So like, how do you feel about telephone work? How do you feel about computerized work or digital therapy, digital interventions? So using Silver Cloud, what are the pros and cons of that? What do you think might be the advantages and disadvantages of that? What do you think might be the advantages and disadvantages of teleconferencing? So using Microsoft Teams, face to face and etc., as opposed to the traditional face to face. Then there's risk, supervision, and like I said, potential role play for risk. Any questions on these? We'll get a chance to ask questions, but I think we're going to touch that. Yeah. Development. I know that one of you asked me a question earlier about development, what happens afterwards. These are the following things. When you qualify, you will later on have opportunities either at your service or any other service that you plan to move to. You get to specialize. So you could specialize, you get training in either perinatal work, neurodiversity, which is becoming big now, LTC, which is also a big thing. Hence myself, for example, I'm trying to specialize. Hopefully in January, I'm gonna start my training for LTC work. And I think don't know if there are other special areas where you can specialize in, but it helps. There's a lot of work needed for different areas. You can become a clinical educator on PWP courses, which is something I'm also interested in. So, you can become a tutor or a lecturer, which is something I hope to take on. I do like teaching. Senior PWP or a lead PWP, this is when you're getting onto a more senior managerial role. So you're either a senior PWP or a lead PWP, you're leading a particular thing. So senior PWP, you're part of the seniors now. You are now doing, you're providing supervision, you're line managing. A lead, you're basically either leading in, it could be a lead in safeguarding, a lead in triage, or a lead in well-being, or a lead in something else. Or you can go and apply for, well, you need 2 years experience, qualified experience, where you can then go and embark on the high intensity training for, high intensity CBT. So you can go on to that. Or as most people, get onto the clinical doctorate. And, the clinical doctorate here is not necessarily clinical psychology only. It's not exclusive to that. It could be counseling psychology, could be a PhD. There are now people who are, which what I'm interested in doing actually is, there are some people who are going down the health psychology route. I've seen at least 2 people on LinkedIn, seen 2 profiles where PWP, they have their masters in health psychology, then they got onto the doctorate. They did their LTC training as well, which helped. And I've seen another person who PWP LTC training, and then he went on to do high intensity. Then he did his high intensity training at LTC, in LTC as well at high intensity, and then he went and he's now currently doing his doctorate in health psychology. So that is an area of interest of my, I've got that area of interest as well. So it really differs. We had someone in my last service, he did the PWP training, and after that, he decided to do more of counseling work. So I think he's now training to become a qualified counselor. So that's quite good. He's got, he's got that PWP work qualification, and now he's going on to do more counseling training and all of that. I know I've taken quite a lot of your time, and I do thank you all for, bearing with me. But I've got a couple of more minutes. If anybody wants to ask any questions, any concerns, anything you'd like to ask. I hope today has been beneficial. I don't know if I met any expectations or I didn't cover anything you guys wanted me to cover, but I thought I'd just give you a glimpse of what PWP life looks like, and, a bit about the application, etc. I hope you guys benefited. And do you have any questions? Go for it.
Hello. I just wanted to say thank you for the presentation. It's been really helpful and informative. I do have a question regarding accessibility to the course. For someone who is still in their final year of their psych degree, is it even possible to graduate and then go on and start this course the following September, or would there need to be some sort of, gap in between? How does that work?
So if I got that correct, you're in your final year
hmm
and you want to apply for this next year, right?
Yeah, potentially. Yeah, I'm thinking about it.
What's your experience?
So I've been working on a psych ward for 2 years, as a bank support worker, and I've been about, is it 3 months, 4 months now, volunteering as a crisis like support texter for Shout.
Very good, very good, very good. You're ticking boxes.
Cheers.
No. I'm serious, because it is possible in 2023. So I was halfway. So when I was halfway throughout my training, one of the girls that I helped get onto the course. So I helped her with her, her personal statement, and I had a session with her. I coached her for the interview questions. And mind you, this is someone who literally graduated, like her undergrad, that that summer. So she graduated July 2023, undergrad in psychology, and she got onto the course for September 2023 and September 2024, a couple of months ago. She now is a qualified PWP. So I never expected that before, but that showed me that it is possible. I think she had the experience. I think the minimum experience you need is 6 months. Now you're telling me you've been a bank support worker for 2 years, and you've got now 3 months, continuous. If you continue, Shout has already you've already ticked the boxes on risk, safeguarding, and even interpersonal skills, because you're learning to engage. Sorry, interpersonal, and so look at that. So safety, risk, interpersonal skills, and engagement. And also the digital. I'm going to add the fifth: your ability to use digital modalities and digital formats of some form of treatment and engagement. So it's already, I've given you 5 things already from that, because Shout, it's all about risk and safety. You're engaging, you're using interpersonal skills to de-escalate situations. You're using text, so you're using a digital form of communication. I would say you have a chance. I can't guarantee it, but I feel that you do have a chance. So don't let yourself down. I would say apply for September. I think you have a
thank
chance.
you. Cheers,
No,
I
definitely. I
appreciate
think you
that.
do. No,
It
not a
just
problem
seems
at all.
like
Not a problem at all.
a really far away idea for someone who's still finishing their final year to be even considering that. So it's,
It will be competitive. I'm not going
of
to lie. It's
course, yeah, of
going to be
course.
competitive. It's in every year. It's just getting more competitive. I mean, even when I met with one of the leads in this new service, I mean, some of the roles, the qualified roles, are becoming highly competitive. But the thing is, people getting onto, because so many people are hearing about the PWP nowadays. Everybody's doing searches, so they're looking for people like myself. They're looking for people like there's a lady called Vicky Lee. I'll share the video with you guys in a moment. I'll send the link to you guys. The people are watching her videos because she did her videos 2 years ago, but I think they're very beneficial. I think a lot of people have benefited from her, and I think you guys will also benefit from her. So it's everyone's just trying to get information, resources. Okay, how do I apply? What do I do? What do I put on my personal statement, etc., etc., etc. And what it is that everybody's just competing. Everybody's got their different experiences. But I want you all to remember one thing: every single one of you has unique experiences. Your experiences are unique. Doesn't matter where you're from. Doesn't matter what language you speak. It doesn't matter. Your experience is unique. It can be worked on. You will increase in your experience, but remember, think about what do you bring to the table specifically, and what do you think can make you the best candidate? You have to think about that question, and I'm positive there is something that you can bring to the table that can make you a unique candidate to that particular service. But that's the thing, you need to kind of really dig deep and find out. What I was going to say is, sorry, I lost my train of thought. It's the time of the day. But any other questions? I hope that was beneficial, Kanan. And if you want, I'll share it with you guys. Just bear with me a moment. Stop sharing. If anybody has any questions, don't hesitate to ask. I'm just gonna see if I